I'm Andrea Restifo, and this is Dr. Yosef Dlugacz, and we're here in New York, bringing you this session today on quality management and how we operationalize it here at North Shore University Hospital, part of Northwell Health System. Just so you know, Northwell is a 23 hospital health system with over 750 outpatient practices. We're really proud of our work we've done at Northwell, and we're really delighted to share it with you. So thank you to the American College of Medical Quality for having us today.
I share the same sentiments as Andrea Restifo, and I hope you'll enjoy this session. We're going to bring you in the future two very practical examples of how to deal with quality and safety throughout your own organization. Thank you. We are starting a very ambitious series of lectures that will bring forth the concept of quality, the implementation of quality management, and the results of performance improvement that leads to outcome. In terms of introduction, I'll introduce myself and then I'll introduce my colleague. My name is Yosef Dlugacz. I have a PhD in sociology, and I worked in the healthcare field for over 30 years, building quality management infrastructures. Started at North Shore University Hospital, then continued to North Shore LIJ, then we continued to Northwell. In that process, the accreditation by the Joint Commission recognized our work by giving us the first award as a system. We got the Cadman Award because we showed how we can integrate quality management processes and structures throughout several institutions and follow-up care from the inpatient to the community. In addition to that, I taught nationally and internationally, and I was able to build with a good team of nurses and physicians benchmark in different areas of analysis. Also, I published 4 books. One of them, the first one with my colleague, Andrea Restifo. The books were well received, and the latest textbook I'm using in educating students in the business school, graduate and undergraduate work, and we are also using the book as a reference to the exam by the medical college. I'll let Andrea Restifo to introduce herself.
Hi, I'm Andrea Restifo. I am a nurse, and I work at North Shore University Hospital, part of Northwell Health. I am responsible for the operations of quality management, which includes our safety services program, infection prevention, performance improvement, and then I have some operational responsibilities for important areas of the hospital, laboratory, blood bank, case management, and social work. In my role, I've seen quality management transition, but the key piece that I do every day is promote the quality management methodology and performance improvement practices. I have collaborated on multiple performance improvement initiatives here at our hospital and in our health system as well. I have published with Yosef in his first book, and as well as many chapters in other books. I've been able to present at conferences, and I am a member of the Live On New York Board of Trustee Medical Advisory Board committee, which I've been serving for several years. I did my undergraduate studies at Villanova and my master's degrees from Long Island University and Dartmouth College. Thank you for letting me be involved in this great educational endeavor.
As we move, as the American Board of Medical Quality, is moving towards accepting nurses into our fold. For Andrea, it will be an amazing opportunity to be part of this important board and also to present her point of views as a nurse on quality. So this should be a very interesting lecture. What we're trying to do in the next 10 to 15 lectures, which will last 30 minutes each, with 15 minutes for room for discussion, so to make it very lively. The lectures are being pre-recorded, so the question and answer, I assume, will take place in another time after people listen to the lecture. And the question and answer doesn't have to be face-to-face, it also can be through emails and so on. So what we'll do in the next sessions, we will give our definition of quality as we see it, Andrea and I, and how we implemented it. Then we'll be giving the CEO perspective on quality management. It's extremely important that the top echelon within the organization accept quality management and also integrate it into the daily operation of an organization. Without this type of integration, quality management tend to fail, not to succeed, and it's also only being used to meet accreditation expectation. Then we'll talk about quality management of tomorrow. This will be the third lecture, and in it, we'll talk about the future of quality, what type of analytics exist, how we move with electronic medical record, and also how data is becoming more and more available, and we can conceptualize new variables to measure process and outcome. The next one would be on a financial point of view. We'll focus on the CFO, and we are going to introduce a CFO, and he will be, or he or she will give an explanation, again, how quality management is part of the budget, how it's being used as an indicator for efficiency and effectiveness in operation. The next lecture will be on electronic medical record, and again, we'll touch a little bit on artificial intelligence, machine learning as a database for understanding processes, intervention, and outcome. When I say we're going to touch upon it, we'll talk about the definition and illustrate an example, because in 30 minutes, we really don't have time to go in detail of how to implement such a complicated methodology. Nevertheless, we'll illustrate that the electronic medical record is becoming a database, and it's also being used not only by the healthcare provider, but by the insurance companies to enhance processes. In addition to that, because of the availability of connectiveness and the electronic medical record, we'll focus on ambulatory practices. We'll talk about the use of dashboard to better understand the relationship between the community for better access and continuity of care and a new model of patient care. And in that way, we can illustrate how we approach telemedicine, how we look at readmission, how we understand length of stay, and how we understand emergency services. The next lectures will focus on medical leadership and accountability. This is extremely important. Without the clinician, quality management cannot exist. In the beginning, 35 years ago, when we had quality assurance, typically nurses played some minor role in nursing, in quality, and physician played even a lesser role in quality. It was mostly done by the various nurses who worked for the Department of Quality Management. Today, it's a different story. Physicians initiate quality. They use quality as a methodology to understand how they practice medicine, a different level of care. Also, we'll focus on accountability in terms of the board of trustees, how they understand quality, what does it mean to them as in their fiduciary role, and how they represent the community and responsibilities to the communities. This will be very interesting. We'll bring a board member to give the talk. I'm myself a board member at Northwell. I have both advisory function and fiduciary function in quality management. The next series of lectures will focus on analytics. We'll talk about statistics and how we use data in terms of control charts, standard deviation, mean, and so on. Then we'll talk about how to maintain quality during organizational change, especially in COVID-19. We'll focus also on the credentialing process, which is extremely important, how the privileges interact, interface with credentialing and quality, how this is being used on a daily basis, and how it goes to the medical board and the board of trustees. The last talk will make it more from a clinical educational point of view to illustrate how medical and nursing school curriculum focus on quality. It's a very important aspect of these lectures. We have an opportunity to bring the Hofstra Medical School and the Hofstra Nursing School into it because when we talk about when quality management was initiated by physician in terms of the Institute of Medicine and the Institute for Health Improvement, 20 years ago, especially when they talked about mortality, they realized that the physicians and nurses are key to all of that, and they need to initiate quality. It cannot come from above. It has to be integrated from the beginning, and the beginning of socialization into quality is the schools. So we'll bring you a very nice example of how the medical and / the nursing school, and maybe even the PA school, how do they integrate quality management into the curriculum? Andrea?
So we're really excited about this first session because it sets the stage. As Yosef pointed out in the offerings that we have, we're really looking to target all audiences because we really see that quality management is integral to hospital operations. And it's not seen as a separate department that's just going to be focusing on regulatory preparation, but really enforcing and reinforcing the consciousness of the hospital through quality management process and methodology. We're really going to highlight the quality structure processes that we've developed and the outcomes we've achieved to better improve our hospital health system and our patients through the continuum of care. We really appreciate the leadership commitment that we see at our health system and that they really want to be part of these sessions that we're going to be teaching because they view quality as a needed action, not a required action for regulatory purposes. We sit together in operations to strategize, prioritize, and the role of the quality professional is so important to that. So we're really excited, and we'll talk a lot about our analytics, our education, and our dashboards, and all the things we do. We have really focused our first talk on the philosophy of value system, safety methodology, and how we apply quality principles in hospital operations and leadership. The transformation from quality assurance to quality management is ever so important, and it will make the program successful because it involves our frontline staff involved in decisions, getting information, and really bringing us to become a high reliable organization looking for zero defects and really applying the principles.
So as you could see, quality is not being established in a vacuum. You need to have a mission, you have to have a vision within the organization, you have to have a methodology that enhances the word, even the concept of quality. What I would like to do here today to make it more interesting rather than an abstract idea of quality, it's not always easy to analyze it or talk about it. I'm giving to you this presentation a picture of a tank. And I'm asking, what does a tank and quality management in healthcare have in common? One thing that they have in common, at least from my point of view, is this is a tank that I fought in '67. And well, I think this is where the ideas of quality came into my mind, not necessarily during the battle, but much later on as I reflected of my work. I was a technician, and my role was to fix basically tanks under fire. And the goal, the objective is to have a quality tank, a tank that can function under all circumstances under fire, a tank that provides a safe environment to 5 people who work within it, and also a safe environment in terms of the success in a battle of this particular tank. So quality assurance and quality control was extremely important. Everything had to be perfect in order for it to move well in different terrains under a fire. So what I did at that point is that I developed principles of quality management. And again, the principles came from my experience in a tank. And of course, people like Andrea influenced my thinking too. Andrea was an ICU nurse, and she also worked in a team in the ICU. She was part of a team. So this was really worked hand in hand, my experience outside of the healthcare and Andrea's experience in the healthcare really brought things together. So the first principle of quality management is that to protect the patient from any danger, from any harm that can come, which means you are trying to develop a safe environment. You're trying to develop an appropriate environment in the same way as I try to make every tank under my supervision to be protective of the occupants of this tank. It's to be committed to providing the best care possible. So the best care possible means that based on experience and based on our different failure mode analysis, we can provide the best care for patients under difficult circumstances. And the best care has to be defined through benchmarking, and it has to be defined and approved by the medical board. So we can continue in that fashion to provide the best care. 3, be prepared to make quick and correct decisions in the crisis. And this is a very important concept. It's like when you are in the fire, you need to think critically, you have to think very fast, and you have to be able to fix things very fast. So a good example of that is that in ICU, which is very technical, with so many equipment, and in surgery, where the technology and a group of people working around technology is very important. So if you have a crisis, an unforeseen crisis, you should be able to operationalize it rapidly and fix the problem before the patient deteriorate. So this is extremely important principle. Be quick to correct the problem, and also be quick in terms of making a decision in crisis, which may include asking for help. Number 4, be prepared to introduce the right intervention in crisis. So the idea of crisis is not only that you do something, but you have to do it well. You have to do it in such a way that you eliminate or reduce the crisis to 0. Number 5, review processes for flaws and maintain vigilance against flaws. So the whole idea here is that if you have a defect, you need to identify it. And typically we do it through Six Sigma. And we're trying to make sure that the defect that we fixed once doesn't come back. This is really critical. So if we have an incident and we developed all of this comprehensive corrective action, and the peer review that we spent so much time on it doesn't come back later on because we weren't vigilant enough in terms of making sure that the system or the process adapted this type of intervention. Number 6, analyze the patient population served to best manage commonalities. So again, it's very important that we treat each patient individually, but if we also have data, we can define a problem in a global way, in a global manner. We can look, for example, at the type of infection for a particular population, and this may help us to develop intervention for that unique population. Number 7, constantly evaluate and review patient care. Like with the tank, in order to make sure that it always works, you cannot say, I fixed it. Check all of the things that you need to check in the book because you fixed it. It's simply, you have to come almost every day, start the engine, start the hydraulics, move the cannon, move the tank to make sure that everything is in a working condition. It's almost the same maintenance type of work that you do on your own car. If you don't do anything about it, especially during COVID, where people didn't drive a lot, things happen to the car. So you have to keep vigilance. And in medical care, is extremely important that as patients come through under your hands, under your supervision, you need to constantly review what you're doing for them to make sure they are not lost and to make sure that the protocol is being followed. Number 8, data analysis. Data analysis is the key to quality management. Without data, we don't have quality management. In fact, as we talk later on, Andrea mentioned the theoreticians of quality in industry at large, even in healthcare. They needed to use data because data can be used to measure a particular process or an outcome, or to tell you whether or not you're in compliance or how far are you from compliance through understanding standard deviation. And number 9, decision-making based on results. In other words, now that we resolved a particular issue, we fixed a particular problem, we are focused on a particular aspect of care, all of this has to be based on results. Otherwise, it's hearsay, and clinician will not comply. Because sometimes, or most of the time, when you fix a problem, you fix a process which takes time to fix and a lot of work. So it's very important, it's based on result, that the audience, the clinicians, accept it and understand it and again, internalize it.
I would add that these principles of quality management and what you showed us with the tanks and when you served really apply to now because of the organization and the communication that you need, and that you operated under difficult conditions to avoid error. And that's what we did during COVID. We had to be resilient, and we had to make sure that the tasks that we were being performed were really very reliable, and that we had a safe culture for our employees, our patients, and our community. So what we see here, we could use the command center structure to make the roles clear, establish accountability, develop what was our important data that we needed for COVID, right? Number of cases, supplies that we needed, PPE, vaccinations, like make a dashboard of important things, analyze it so we could predict what we would need for the next day, next week, as that crisis kept going. We could develop checklists as we learned about what we needed and that we could apply to bring to another hospital. We could really apply the lessons in any environment that we had to manage COVID and then share and communicate our results, working as one team, one unit for the same purpose. And I also see here that how important training is, right? And competency is, because you can't have an error in when you're working in these situations. So it really applies these principles to what we do today.
Like it's all in, it helps you to internalize it. So it's your part of your daily work. Can you imagine if you only did quality in a tank because the sergeant inspects you, then you would not going to have a good product. You're not going to be ready. The same thing is here. If you're only preparing for Joint Commission, you don't have quality and you're not going to be ready, in spite of the fact that you pass accreditation. You don't have quality. So this really brings us to the next work. And Andrea, if you don't mind, you could talk a little bit briefly on why quality. And then the next one is contribution of quality theoreticians.
Sure. You know, when we look at why quality, I think about when we are with our Hofstra students, because they are business and students and informatics. And we really try to work with them on defining quality and that it is easily recognized. And when we don't have it, we miss it, right? And that can be when we go car shopping, go to a restaurant. But when we want to get the definition, it's hard to define. So we know when we experience it, we know when we're missing it. And it can be considered an attitude or orientation of one person or a group, but it is about perception. So the next piece that we really wanted to talk about in this why quality is these quality theorists help define quality. And what they did is they looked at it from different angles, right? Whether it was from a consumer getting infection with Florence Nightingale to the production of industry, through process flow, through consistent quality improvement. And these theorists really looked at why things were having defects and what led to outcomes, and really started to use data and flow out processes to understand how things were designed so they can improve the design of the system and take out the defects. In the theorists, even though they all were not healthcare, the theorists have many applications to quality, because when you're looking at the quality environment, you have to have a sense of trust, respect, and dignity. You have to act, as Yosef said early, on new ideas and fix problems while they're small so they don't become big problems. You have to really look at your consumer and what their needs are and apologize and really figure out if someone's needs are not met, why. And we have to empower our employees and make them responsible. And then we have to implement statistical control processes to know if our process is in control and that we can really reflect on if our change was successful or not. So the theorists I see really are the foundation for what we are today. And I think in the bottom right-hand corner, you can see Yosef really, in his theory, summarizes what we've learned from the past and can bring it into the future and how we made our principles. The education, creation of the databases, really defining numerators and denominators, which we do often in our classes, as well as look at communication improvements and enhancements as we see that happen. The lack of communication can lead to problems, and really help people understand how processes and outcomes can be correlated. So just building on this, we have, traditional structure, process, and outcome. In this particular framework, we've added the people piece.
Mm-hmm.
So.
And this is really important framework. And again, I'm going to repeat what Andrea said. Quality is based on structure that must exist. If it doesn't exist, there's no quality. In other words, until now, we had a Department of Quality Management, and this was perceived to be the structure. but we need to move into, and moving already, where the hospital is the structure for quality management, not a department. We need to have a process, and the process means that we need to have data, we need to have analytics. In fact, we have to have a whole big department of information technology where it's not only providing the technology, but it's also helping us to harvest the information, to translate the information into variables and data that is appropriate for analysis. And the last one is people. At this stage, the individuals, all of the individuals who are part of the organization participate in quality. So it's not only the chief medical officer or the chief quality officer or the chief nurse, but it's everyone. It's the people who work at the bedside, the people who provide nutrition, the people who clean. In my previous role in quality management, I focused a lot on the people who provided routine or almost work that people didn't see. And I said to myself, wow, this is really interesting. Without those people, we're not going to have an infection-free environment. Without these people, we're not going to have patients who are being fed well. Without those people, we are not going to have patients who don't fall or fall. So we need to make sure that we recognize those people, that we cultivate their knowledge and get information from them to understand how we provide patient care at the bedside and how quality is being implemented at the bedside. So bedside quality is the most important unit of analysis in all of this framework. Yes, we do have committees, we do have formal processes, but we need to have the people at the bedside to continue in providing quality management.
The one thing I would add, though, is with the people, we know that humans are going to make mistakes, and in quality, we expect them when we prepare for them. And with people, that involves communication, and we know that we have to get rid of the barriers in communication, as we said earlier. But the framework for quality puts the patient first and foremost, and that we really want to ensure that patient care is safe, effective, patient-centered, timely, efficient, equitable, building on the previous IOM Institute of Medicine requirements. So this framework really adds to that and is something that we use here at our health system. As we close this particular first session that we have, and we look forward to sharing many others with you, we really wanted you to think about, as you leave the course, how do you make the case for change? And this is an example that could happen in any organization, that you receive information about surgical mortality being high, and what would you do about it? So our take home for you is really think about this case for change and look at the pros and cons of different actions, and what would you do if this was in your organization. So we really had a wonderful time recording this first session for you. We are available via the internet to answer any questions, and we look forward to the next sessions.
Yes, the next session will be on the application of quality management.
Okay, thank you, DJ. Thank you as well. We'd be very happy to take questions. I know you're encouraging that in the chat.
Yeah, like I said, haven't seen any come through yet, but please, anyone, if you do have any questions, please put them in the chat or Q&A section, and we will address those now at this time.
I can say something until the questions come. I know that not everyone likes to ask questions in the beginning. Maybe they'll ask later on through email. This is fine. But what you see here really in the first presentation is an accumulation of combined work for 30 years or more at different level of care in the organization. Quality management, as we know it, evolved over time. We focused on, in the beginning, on quality assurance, quality management with developing indicators as the Joint Commission required of us. And then we focused, of course, on adverse outcome for incident processes, and then develop preventive action. So all of those aspects of quality management definition, we can provide, if anybody is interested, we can provide real examples, and people can share or figure out how to implement them. As Andrea mentioned in the request for change, the case for change, how we're going to do it and what does it take to do it.
We did get one question come through, and the question is, what do you do if your senior leadership or organizational leaders just don't get it when it comes to the quality principles you described? Okay,
I would like to, first of all, to say that the individual who asked the question, unfortunately, it still takes place. In my 30 years or so of working quality management, it's very difficult to convince a CEO to change, because many of the CEOs didn't get this type of education. They feel that quality management is something that regulatory requirements are requesting, or sometimes there is a bad event, they don't want it in the media to be illustrated or described. So what I did, and Andrea can also talk about it, slowly, very slowly, as I presented incidents to the CEO, I did it privately. And in the process, I taught the individual what it means, how those corrective action that we took a long time to prepare do make an impact. And then over time, I also was able to convince CEOs that reduction in adverse outcome, improving in processes, and meeting expectation in terms of benchmark data really helps the organization. It really makes them a profit. I mean, I couldn't show exact cost benefit analysis, but I did illustrate that a reduction readmission really can show an improvement in the bottom line. My biggest project that I initiated many years ago was reduction length of stay. And by reducing the length of stay, I was able to really show through finance, wow, we're making money. In fact, making good money. And then reduction and making sure that people, their beds are being occupied again, we made even more money. And by reducing readmission, we even made more money. So this was my biggest project, that how I influenced CEOs, and then the whole momentum of quality management changed within the organization. And the second project I'll never forget, it was reduction in C-section. We followed the same process to show that the bottom line is affected by not having reduced it. Andrea?
I would say, and looking at that last case for change, sometimes we need to break it down into the type of patients we're having, if it's a selection process for high mortality, morbidity, and surgery. Did we optimize the patients good enough prior to a procedure? We can look at the technical skills of the individual and make sure that, do they have anything around in a system that's challenging them? Do they feel rushed? or is it the team that we can improve skills on? We also look to standardize things. I mean, in a case with the cardiac surgery, are they using the same equipment and same antibiotic choice and drapes? We found that different people used. So again, it was a cost savings, but it was a standardization to prevent infection. And then we look at the data pre, post, and do the plan, do, study, act to see if the interventions we had, and sometimes they are multiple, made a difference. And in some cases, we have to put programs around just to, okay, if there is a bad outcome, do we need to bring our advanced illness team in to help that team when they get triggered? So we take it each scenario differently, but we really do try to look at the structure we have and how to improve process and outcome.
Yeah, I want to add one more comment that the bottom line is that quality management has to be on the floors constantly to change the culture. In the same time as I was in Andrea on the floors, talking to the environment of care, for example, with the CEO, it was the same thing. Constantly talking so the culture can change, the attitude about quality can change and can be accepted.
We did have another question come through. Someone writes, getting good data on quality priorities can really be a challenge, and with many outcomes require institutional investment. How do you get support on this important need, or else troubleshoot when you do not have the data that you want?
Oh, it's an excellent question. It's in fact, this question is becoming more and more relevant. Most organizations now have computerized medical record. And the computerized medical record can spit information. The difficulty is that how do you translate the medical record into a database with consistent variables? This is the key. So besides having a good computerized medical record, you need to have also an analytics section. And I know that today, IT, especially in large organizations, does analytics. But I believe that quality management must have its own analytic groups. And in this way, they can convert information into data. And it takes time. It doesn't happen overnight. This is one part. And the reason that you want analytics is that you need to have people who understand statistics. In the same way as the finance department, this is where I developed the model, is based on finance. Our finance department always had an analyst. So the analyst was not only to produce data, but to analyze data. So the data makes sense to the CEO and the board. And in quality management, it's the same today. I worked very hard to develop the same processes. So the audience, who is the medical staff, the nursing staff, and any other professional, including the executive suite and the board, understand. So if we say we have such a variable as length of stay, it's the same measure, no matter who looks at it. So the length of stay, for example, if it's based on discharge or based on admission, it has to be the same way to be calculated. And then, of course, I taught them how to develop numerators and denominators. So those are the keys. Once you have it, it's easier to prove to the people who make decisions, especially in finance, why this data is important. And then you can develop further good information system to be studied, to be analyzed, and to be used for improvement.
So for me to get resources, and that's not easy in quality to do, we have a strategic planning meeting and we outline our strategy for the hospital. So right now we may be wanting to expand the transplant program.
or get better external scores from CMS or US News and World Report, and we'll come up with a plan on, a resource that's needed to do, or partial resource. So a lot of it is external priorities, new programs that we can do. We've taken on more responsibility in our quality departments, like we have administrative policy, so that was able to get a piece of a resource as well. So sometimes we piece it, and sometimes we make it as a plan for a new program or external requirements. But reputation is a strategy here at the hospital, and in order for us to better serve the community, I'm very fortunate that our CEO gets that when it comes time to resources.
We did have another question come through. Any suggestions on explaining variations such as common cause versus special cause to leaders? Often they will look at few data points and make incorrect assessments on what the data is telling them.
It's a very good question. And this happens constantly. You need, as you present your data, you need to leave at least 3 minutes to provide background to the data and ongoing education. So you need to explain to the CEO or to the trustees or to the medical board what is the common variation, why those variables have an impact on the dependent variable. Or if it's a single, explain. So when I looked at, when I was asked by the board to look at mortality for open heart, there are many causes. And you need to statistically explain it. So we did it through a very sophisticated regression model where we taught the board which variable correlate with the mortality. And then what type of processes we need to implement to reduce those variants. So this is the key. So it's to be well-versed in statistics. You don't have to as a quality management, but at least you know how to ask the questions, but your analysts have to. And then develop processes to reduce it, the variation. And this takes time, but in the end, they do listen to you. In the same way as they listen to the finance committee when they talk about not meeting the goals, or the budget is over or under. The same way, it's the same, we look at the same causalities. Andrea?
Yeah, I would say we try to use the, the fishbone just to also go through when we have an event. We are able to bring in a large team that's interdisciplinary, physicians, residents, nursing, and those people at the bedside that are on the front line as well. So they can help define the cause of the problem and focus more on the main problem and not the special cause. And, I find it's very easy to get stuck on a special cause, but in a large group, we're able to, with an executive sponsor on an incident and a team facilitator, go back to the bigger picture. So that's how we do it here on a day-to-day basis.
We did have another question come through.
Sure.
In a pathology lab with a CLIA medical director who is a physician and is ultimately responsible for what happens in the lab, do you have any best practices or lessons learned in keeping the physician engaged in the quality program, which is generally overseen by the operations side of the hospital?
Well, I'll give you an example.
I would say also get involved in the hospital initiatives. That I think is really a help, but go ahead.
Yes, this can happen in spite of the fact that in pathology, quality control measures exist. They always existed. And quality management protocol always existed for different type of analysis. if it's a tissue analysis, if it's radiation, and so on. The way to get the medical director involved is that in the past, what I did it through an incident. Today, I do through benchmarking. If our data shows that we are above the benchmark or more than 3 standard deviation away from the mean, I'll talk to the quality management representative in the pathology, but together with the medical director. So he or she really understand what needs to be done and what needs to be changed. Because this type of improvement is really required by the American College of Pathology whenever they come to do evaluation of the lab. So I like to do it through examples. It's either benchmark or an incident. Andrea?
Yeah, I can say here at North Shore, our lab medical leadership was very involved, obviously, in COVID, but we involve them in blood utilization. They are the co-leads with our anesthesia department, as well as the lab coming to administration and saying, hey, I could save you a lot of money if you would stop testing people that you just had a normal yesterday and today's test is going to be normal. So we do some data on repeat normal labs, and that's really cost savings and patient-centered, not to be stuck so many times. So sometimes it's an idea from the lab that we push forward, or something that they're partnered with another department. We have our lab involved in a lot of initiatives here, patient identification and the readmission efforts here, sepsis efforts, because they're part of the process, and their input is really valuable.
It doesn't, oh, we do have another question. Someone writes, I really like the question about keeping physician leaders engaged in quality efforts. Many times physicians are too busy to get involved in the everyday QI work. How do you balance the many pressures on the time, but how do you balance the many pressures on their time and but need for their involvement and their support to critical success?
First of all, it's not your job to balance their time. They need to figure out how to balance their time. So quality management issues should always come from the medical board where they participate. And constantly talk about it, constantly reminding them about the measurements, the expectation, the analysis. This is one part. This is the formal part. The informal part is simply to do it through an incident. There isn't an organization that doesn't have incidents. Everyone has incidents. And we have lots of them. Some of them have an impact, some don't, but we do have them. So my suggestion would be is that to look at the near miss and the incident themselves and meet with a physician. And in this process of meeting, explaining slowly, not at once, but over time, what are the expectations in terms of their role in participating in quality and safety.
I think in our site, we've been very fortunate. Our medical directors all had great quality backgrounds because they were involved in the day-to-day quality, whether that's an incident, a performance improvement initiative, or some chart review on utilization. I look at it as a growth potential for them. I think it's part of development, and we have programs here to grow physicians, and quality is part of that curriculum. So I think that's a plus. Sometimes departments will allot some administrative time, but usually the docs end up doing it as a, because they're passionate about it and they want to learn more. So different departments have different models, but if that doc really wants to, I think you can be successful at it.
Okay, it doesn't look like we're getting any more questions coming through. So we can go ahead and start wrapping up. I don't know if you guys have any closing remarks that you'd like to add before we end this session.
I only want to say that one, I really enjoyed it. I like the questions. They're very good questions. And those questions, I'm sure, will repeat themselves in the next sessions too, because there are new examples, new pressures, especially today. the organization are going under the COVID. There are so many pressures, but yet we need to focus on quality because COVID is one crisis. We may have more crises. So it's an important educational program that we would love to see grow and continue. Also the next session, we'll try to bring more examples as we speak about quality and safety management.
Yeah, no, thank you very much for having us today. And I echo what Dr. Dlugacz said. Thank you.
Okay. Thank you guys. And thank you everyone for attending, and we'll see you again next time.
Thank you very much.